has told us about more frequent and more extreme heat waves and more frequent fire weather, just to mention a few of the climate change impacts affecting our health. The impacts we see today will increase with further global warming, and we know that the most vulnerable people are often the most vulnerable countries of the world are most affected. Facing the increased climate and health risks, more intersectoral collaboration and knowledge exchange between the climate change and health research communities, policy and practice is needed for integrated and evidence-based action for mitigation of and adaptation to the health impacts of climate change. In the view of connecting climate change and health, it's an honor for two climate centers to be convening this event here at the Health Pavilion. In the session today, we bring together health and climate researchers with practitioners to discuss adaptation options for key climate and health risks. In the panel today, we have 4 researchers who will update us on knowledge to different aspects of the climate health interface, each bringing a different perspective to the issue. We will cover air pollution, including from wildfires, occupational heat, environmental heat, and climate-sensitive infectious diseases. These researchers are part of or connected to the EU-funded project NBEL that is bringing together leading climate and health research projects. After this presentation, we will bring in policy and practice perspectives to hear how we can take the knowledge from science and apply it for policy on the EU level, internationally, and in the practice of humanitarian organizations. And we will discuss how risks come together in the form of complex events and the practical next steps for countries, citizens, and companies to reduce impacts on the most vulnerable people. And we will have a discussion with our speakers and the audience. For our virtual audience today, please post your questions for the panel in the Q&A in Zoom. Our first speaker this afternoon is Kristin Anand, a research director at Cicero Center for International Climate Research in Norway, where a key part of her work is addressing the benefits to human health and climate from reducing emissions of greenhouse gases and air pollution. Kristin, can you tell us how climate change and air pollution are related and how they affect human health?
Thank you, Miriam. I plan to give a brief introduction to the link between climate change and health using some slides. So I think I stand over here. So the connection between climate change and health is manifested. I will talk about 3 main links. The first is common emission sources. The second is the atmospheric interactions between climate change and air pollution. And the third is the health interactions. So the first one is very simple. We all know greenhouse gases and air pollutants often have the same sources. Particulate air pollution and ozone are the 2 main air pollution components when it comes to human health damage. These are very complicated components. It's not like PM 2.5 is one thing. So both for PM 2.5 and ozone pollution is partly related to atmospheric processes. So they are so-called secondary components, at least to some extent, for particles. And these pollutants are caused and are created due to a myriad of sources, and both have a complex formation chemistry. But importantly, fossil fuel burning is a major source. And as we all know, fossil fuels is also the dominant source of CO2 emissions. So this means that very often we have immediate benefits for air quality from mitigating greenhouse gas emissions due to the reduced emissions of co-emitted air pollutants. However, unfortunately, the reverse is not necessarily the case. Measures for improving air can actually lead to enhanced global warming that is related to particulate pollution, some of them, not all of them. So atmospheric interactions, the first point. Climate change penalty is a term being used in this respect. That simply means that there can be a deterioration of air quality due to global warming. And this is related to very complex processes. So just the keywords. There are impacts on natural emissions when temperatures increases. So there are more evaporation from, so we call biogenic emissions, for instance, from plants and trees. There's also linked to mineral dust. So when it gets very dry, there might be more mineral dust in the atmosphere. So there are also interactions related to the impact of anthropogenic emissions. So when it gets hotter, we need more cooling. Of course, then we might also need less heating. So something is going on in both directions. And there are also impacts on chemical and physical processes in the atmosphere. And these are also very complex interactions, some leading to larger air pollution, some leading to less air pollution. But to summarize what we know so far about this interlinkage, the climate penalty is there, but it's more evident for ozone than for particulate air pollution. But we also understand that the climate penalty effect on concentrations of air pollution is overall less important than changes in atmospheric emissions. Second point related to atmospheric interactions, when it gets very hot and very dry, and maybe the wind, extreme wind speeds, that is what we call fire weather. So this enhances the risk of wildfires. And wildfires is an important source of air pollution. There have been attempts to estimate the mortality impacts of air pollution from wildfires. So this is just one example, a recent study estimating that maybe up to nearly 1% of all deaths during the period 2000 to 2016 were caused by the acute effects of wildfire smoke. And this is only acute effect. There might be long-term effects as well. If I put these two maps together to indicate an important point, because if you see the map to the left showing the places where we have information about the particulate pollution from wildfires and mortality link, there are some large regional holes. And if we look at the other map at the right, we see that the global fire energy release, which is an indicator measured by satellites, we see that there are large regions in the world with extensive wildfires that is not covered by the regions that we have information about the health effects. So this is an important knowledge gap. The second point, or the second point was about the health, or the third point was about the health interactions. And the thing is that temperatures and air pollutants can actually interact through physiological mechanisms to amplify the damage. So very briefly, many studies report interaction between particulate air pollution and or ozone and temperature effects. So the conclusions from reviews indicate that very hot and very cold temperatures enhance the impacts of air pollutants, and vice versa, high levels of air pollutants enhance the heat health effects, which is indicated with this figure. So the last point related to the third point, health interactions, is the fact that there are indications that particulate matter from wildfires might be more toxic to humans. So studies find that there are stronger effects on mortality and longer lag time than for wildfire PM than for urban PM. And this could be because there is a higher fraction of small particles, and they contain more health damaging components, the wildfire emissions. So at CISRA, we have this project called Exhaustion, and we have tried to simplify and visualize all these complex interactions between climate change and air pollution in one figure. It is made by Info Design Lab based in Oslo. You can go to our website and download the figure to study these interactions more carefully. So briefly, the conclusions of my talk. Reducing fossil fuel use will save lives due to reduced global warming and improved air quality. Global warming comes with a double climate penalty, because not only can global warming lead to a deterioration of air quality in itself, but hotter temperatures can also worsen the physiological effects of air pollution. So what are the policy implications? 2 points. Heat stress and air pollution should be considered jointly in policy development, For instance, heat health action plans should include the enhanced risk related to air pollution exposure during heat waves. Secondly, vice versa, air pollution abatement policies need to take into account that global warming will make it more difficult to reach air quality targets. And with this, I say thank you.
Thank you very much, Kristin, for your introduction. And if anyone has questions to Kristin, please post it in the Q&A in Zoom, and we'll get back to that in the discussion section. Our next speaker is Jason Glazer. He is the CEO of Isla Network, an international research and occupational health organization dedicated to protecting workers from the fatal effects of heat in a warming world. Jason, we know heat waves can be deadly, but what is needed to address the issue of workers getting sick and dying from occupational heat stress?
Great, thank you, Miriam, for the question. I just want to do some thank yous and I'll dive into it. I'm going to switch to slides to get my face off the screen. But I really want to thank everybody at Cicero and the Red Cross and the Red Crescent and the WHO who made this possible. And I'm going to show some photos today. I want to make this as broad as possible to hit as many hearts and minds as we can. And so I'm going to show some photos. And if you're at COPE and you want to see more photos like this about the work that I'm going to talk about, you can see Ed Cashew's work, incredible photographer, at the Walkway 6 gallery at COPE. So with that, I'm going to switch over to my slides and take it from there. Are we live at the slides?
Yes, we are.
Wonderful, thank you. So what I'm really focusing on, what we're focusing on, is heat stress and heat illness. And I think a lot of people have confusion about heat stress and some of the outcomes. They say, oh, it's hot everywhere. Why aren't we seeing more of these issues, both the short term and the long term? And you know what we have to think about is that combination of the environmental heat, that high environmental temperature, and then the people who are working the hardest and the heaviest jobs, these very high workloads, building up their core temperature, and they're unable to expend that heat into the environment because it's so hot and humid. And obviously that's already here, that's already happening in the tropics. And as climate change takes hold, it's hitting into the more temperate regions as well. And so the immediate risks that we can talk about, and I think we saw this summer, especially in the Pacific Northwest, and people have been dealing with in the tropics for much longer, the Pacific Northwest in the US and Canada, that is you see greater health risks in general. You see increased accident risks in general because people get dizzy, they get disoriented, they can cut themselves, increase falls, and even increase traffic accidents and uncooled vehicles. And you see reduced productivity. So nobody's really coming out ahead without protections in these conditions. And then of course, there's early mortality because of some of those increased accidents. And of course, heat stroke outright can kill you. But what I want to talk about today also are some of the more pernicious effects. And there's a form of kidney disease that is certainly associated and related to this. And we've shown we can prevent its the damage that leads to it through pretty common sense occupational interventions. And while there may be, and there probably are, other drivers of any chronic disease, this is something we can do something about with current policy, current access, and current know-how. So typical CKD usually affects older people, people with diabetes, metabolic syndrome, hypertension, obesity. It's quite easy to detect with a dipstick for those of you who are in the healthcare field through proteinuria. And it's quite widespread and it's worldwide. But what we're seeing with chronic kidney disease of non-traditional origin is disproportionately affecting working age males and the toughest jobs. They're doing strenuous labor and they don't have really basic interventions like water, rest, and shade to protect their health, keep their core temperature down. And it's tough to detect. This thing is a human rights crisis, a labor crisis, and a health system crisis that has gone on undetected all over the world for at least 40 years. And that part of it is it's harder to surveil because you have to take serum creatinine because of the part of the kidney that's damaged, especially in the early phases. And that's really a problem because, you know, for years I was always told, oh, it's not here in Guatemala, it's hot, we have these industries, and sure enough, it's in Guatemala. The same in Mexico, the same in parts of India. And when we actually use our protocols called the degree protocol to look at the prevalence of this disease in different communities and occupational settings, if it's hot, if people aren't afforded those basic protections, and if it's really tough work, we see this disease. We have yet to see a negative with that combination. And so who am I talking about? I am talking about those doing just the very toughest jobs. So like in Central America, you see sugarcane cutters, but you also see gold miners, salt pan workers, like in Pondicherry in India. And then we are seeing increasing reports of folks coming back from Nepal, or going back to Nepal from the Persian Gulf states who've been working on the World Cup construction and other construction in the Gulf. And they have this disease. So this is really troublesome. When I started working around 12 years ago, I would hit these sugarcane fields early in the morning and stay there all day and watch. And these are otherwise very sophisticated operations and industries. And they're receiving support from the World Bank finance institutions and the IDB, the Inter-American Development Bank, and they're providing basic commodities to the global market and major brands. And yet you have these workers in the thousands working without just fundamental protections. You can see this fellow back in the bad days clearly did not have appropriate PPE, personal protective equipment, did not have access to water, rest, and shade. And they were working 12 hours a day, 7 days a week. So things were getting worse, not better as far as labor. There was more monoculture, more industrialized labor, and less farmers providing for these farms. And you would see this in other industries as well. But I want to kind of shift it to the human cost. Our research is available online. If you're interested in reaching out, I'm happy to share it. I've got colleagues from other research outfits working on similar work today, and we're all happy to share the research. But what does this mean for people on the ground? Like, how do we humanize this? And so this fellow Ramon is now departed. He was already sick with kidney disease in his 30s. It's a photo of his father in the background. He died later in life, but of the same disease. And what we've seen again and again are widows left behind from this disease, and they are now entering the workforce, which didn't really happen before. And children enter the workforce either through subcontractors or even direct contracting still in many of these jobs. And it's certainly not limited to sugarcane. It's just sugarcane is a dominant crop in this environment of high heat, formerly really poor labor protections, though that is improving. And so, this just has this knock-on effect because we're removing people like Ramon from being their prime earning years and supporting their communities. And then kids are leaving school to enter the workforce. So this is a development crisis. This is something we can do something about. And, the burden on the health system is kind of terrifying, right? Because now you have this burden on the economic system, on the production system, removing healthy workers, formerly healthy workers from their prime earning years, which has a knock-on effect, obviously, on child labor and local communities and economies. But what happens then when you have to treat one of the most expensive diseases to treat in the world? And you either can't provide good hospital hemodialysis, which is already very expensive. And when you try to do it in the home, people often die of infection because you can see the living conditions are not adequate at all to be providing home dialysis. And yet major dialysis brands are continuing to do this, even though people are frequently dying of infection before they're dying of kidney disease. And you kind of see the whole story right here in this image. This guy's only in his mid-30s. Obviously looks much more emaciated and older than he should. His son then goes and replaces him in the field. And that's really something we want to interrupt, right? The knock-on effects of these diseases due to heat are really important to consider. And so, what do we do about it? I think the fundamental thing is there's more research to do to look at, cofactors and other causes, other drivers, sure. But, this is one risk. This is one thing that we can ameliorate, that we can address immediately. And if you just say it out loud or to yourself in your head, it's water, scheduled rest, shade, and sanitation, because more women are entering the workforce and they certainly should be given a place to take care of their needs if you're telling them to drink more water at the workforce and they're working with men. But we've developed these systems that are highly organized, and then we assess how well they're implemented, because just having a program is not the same as having a well-implemented program. And while the basics are basic, fundamental, on a 70,000 hectare sugar farm, for instance, or a major gold mine, this becomes more complicated. So how do you make sure you have the appropriate training, the appropriate buy-in from the workforce on up? And we've done return on investment studies to show that, in fact, workers produce more or the same, and that the employer actually has about a 33 cent on the dollar return on investment. So this is really good for everybody to provide these basic protections. And what we've shown is a reduction in injury. We've shown a reduction in hospitalizations due to acute kidney injury. And we believe we'll see a reduction when we look at our long-term follow-up data soon on the incidence of disease. So this is a very exciting time. But I think we do have to ask ourselves some questions. How do these basic protections evade implementation for so long in the leading development programs in the world, like supposedly helping the bottom rung? And how are they missing from big brand supply chains? The good news is I think we can assure them today through programs like PrEP, which is prevention, resilience, efficiency, and protection for workers in a changing climate. And that's the program we're working with at MBEL and through the European Commission. And then the Adelante initiative, where we brought together leaders in the sugar industry like Bonsucro, the sugar mill San Antonio, and other leaders to try to show what's possible in one of the toughest environments and one of the toughest jobs, so that we can expand these implemented and assessed interventions to other locales and geographies and other industries. So it's really the basis for change. And what do we do together? We have to come together, I think, and we need to build up the surveillance to detect this disease. We need to develop and assess the preventative programs like Adelante with the other industries, and we need to have governments involved to consider regulation and assessment of work sites. We definitely need to improve treatment and access to it and assess the cost of this. But we have to support employers, brands, development agencies, and workers in improving and assessing the risk and how we address it, and how then we can make sure that workers are protected going forward. And I think it's just a very clear situation where there is a win-win-win. This is not a zero-sum game, and there is a clear way forward. But change doesn't happen overnight, and it's going to require some reflection and discussion and real buy-in and convincing that, while there might be other drivers of this kidney disease, although there aren't really other drivers for heat stroke that are relevant, this is one you can do something about. This is something you can take ownership over. And if you implement it well and assess that implementation, you can save lives. You can at least extend lives and mitigate the risk for people. And I think that's what our work is really all about. So thank you so much for having us. I think there's a pretty clear way forward on this. And it's just been an incredible pleasure working with my colleagues through NBEL and through Cicero. And thanks for helping put this on the map in a really important forum. So thank you so much.
Thank you so much, Jason, for sharing this with us, and also for showing some concrete work on the ground that can help the people affected. So our next speaker today is Shari Kovacs. She's an associate professor at the London School of Hygiene and Tropical Medicine. And she's been researching the effects of weather, climate, and climate change on human health for more than 20 years. Shari, I want to ask you today, why are pregnant women and children particularly vulnerable to climate change?
Thank you, Miriam. So I just want to thank the organisers as well, WHO, the Red Cross and Cicero for this event. And before I answer the question, I just wanted to say how important it is that health is now a priority at the COP, because this is the first time that this has happened. So thank you all for joining the session. I'm going to briefly talk about some of the results from our CHAMNA project, which is about climate, heat and maternal and neonatal health in Africa. So why are women particularly vulnerable to climate change? Well, pregnant women and young children are very vulnerable to climate change. They currently bear the brunt of disease from poverty and environmental factors. We also know that there are about 300,000 maternal deaths every year, and the majority of these are in sub-Saharan Africa and South Asia. The vast majority of these deaths are preventable and entirely avoidable, but they're caused by lack of access to health services and lack of social protection measures. And we know climate change is already affecting the world's most vulnerable people. It's affecting livelihoods. And not only that, extreme events cause loss of income, and the impacts on health from extreme events cause additional out-of-pocket health expenses. And all these factors push women into poverty. And women in poverty are likely to be at risk from the adverse effects of pregnancy and ill health. But we also know that high outdoor temperatures cause direct impacts on pregnant women, and that's more of the focus of our research project. And it's worth noting, we know from all the climate information and the talks at this meeting, and also from what Jason has just been describing, that we're experiencing new and higher temperatures and new heat waves. So pregnant women everywhere are vulnerable to heat because we just haven't adapted our systems, our health systems, and our behaviours for addressing or managing these new risks, essentially. And one of the main purposes of our project is to provide the correct evidence, evidence-based advice to pregnant women for dealing with these heat risks wherever they are. So what is the evidence that heat affects maternal health? In our research in CHAMNA, we're using epidemiological methods primarily to quantify the impacts of heat on a range of outcomes using health data on mothers and babies in Africa, in East Africa, Southern Africa, and West Africa. But we're also using qualitative research methods to develop interventions that are both acceptable and feasible. So we have very good evidence that high temperatures increase the risk of preterm birth, the risk of stillbirth, and low birth weight. And we know that babies that are born with very low birth weights have lifelong complications and lifelong health problems. So this really is a kind of transgenerational or intergenerational impact of climate change. And there is emerging evidence around the impacts of high temperatures on maternal hypertension and preeclampsia. And preeclampsia is the most important complication in pregnancy and responsible for some of that high burden of maternal deaths. And we know from other evidence that infectious diseases are also very sensitive to weather patterns as well. So women are at risk of those. And we're trying to find out which women are most at risk. So we're looking at modifiers of these types of associations, and that information can be used to target interventions. And as I've said, part of the project is looking at qualitative information. So we've been talking to pregnant women, to new mothers, and to health workers in Kenya and Burkina Faso about their perceptions of heat risks. And this has shown that their high temperatures cause a lot of anxiety, a lot of stress, lack of sleep, but also significant discomfort to mothers and newborn babies, and it interferes with breastfeeding and may increase supplementary breastfeeding, which is, so that's giving babies water or other liquids, and that of course can increase the burden of disease and risk the health of the infant. But what we also found is access to health services may be impaired by high temperatures. Women are very reluctant. If they have to walk to the clinic and they're very pregnant, they're very reluctant to walk in high temperatures. And there's a big, strong association between antenatal visits and adverse health outcomes. So a key part of our CHAMNA project is to provide interventions. And as Jason said, there can be, especially low cost and cost-effective interventions for managing heat risks. So we're producing evidence to increase adaptation actions within the health systems, within clinics, hospitals, health workers, and community midwives and nurses, and also directly undertaking behaviour change interventions, talking to mothers and their relatives. And heat is an occupational risk. So we're also looking at the impacts of heat stress on health workers. You know, in delivery rooms, very high indoor temperatures are reported in health facilities where women are delivering. And we're currently evaluating 2 such interventions in the project, and we'll be able to report on that next year. So those are the key points I wanted to make, and thank you very much. But I just want to say that if you are interested in maternal health and climate change, there's a session focused on this in the Health Pavilion late on Friday afternoon that's being run by USAID.
Thank you so much, Shari. And now we have the 4th research speaker, and I would like to remind the speakers to try to be brief so we have some time left for discussion at the end. Next out is Amir Sapkuta. He is a professor at Maryland University in the US. His research group focuses on the intersection of climate change and human health, with a particular emphasis on cardiopulmonary, renal, and diarrheal diseases. And I want to ask you today, historically, early warning systems are used for climate hazards, but we understand that you are extending them to health as well, and particularly to diarrheal diseases. Can you tell us about your work and how this work may enhance the community resilience in the regions where you're working?
Thank you, and good afternoon, everyone. First of all, I want to commend the organizers for bringing this panel together. And like Sari said, it's great to see that health playing such a prominent role at COP26 meeting now. To get back to your question, yes, absolutely. Early warning systems have been used in the context of climate hazard, but we have to remember that these same very hazard also kills people, makes them sick. Hence, there is a need to make early warning system to protect public health. So that's a lot of the work that I have been involved in. So sort of like historically speaking, disease surveillance has served as one of the foundation of public health, right? So we have the system in place that detects underlying disease dynamic in a population. And if we sense something is wrong, then we go and respond to that, right? So that's how we contain outbreaks and so forth. And generally speaking, that approach has worked relatively well over the past century, except for the most recent pandemic, of course. But the threat that we are dealing with, and particularly these climate change driven threats, are very different. So we need a different line of thinking, new approach in dealing with it. And please remember that climatologists have been telling us that extreme weather event will continue into the foreseeable future despite mitigation effort now because of the changes that have already taken place, right? So people are dying from it now, right here at present. So this poses a fundamental question, and that is, how are we going to adapt to this new set of hazards as a society, right? So what we need is a system that can help us anticipate these threats, prepare for these threats, and respond to those threats, right? And this is where early warning system comes in. So in our particular case, we are trying to develop early warning system for diarrheal diseases in the Asia Pacific region with sub-seasonal to seasonal lead time. And I will come back to the notion of lead time in a little bit, but first of all, why climate change and diarrheal disease? Well, it turns out warming temperature promotes bacterial growth. These are some of the causative agents for many of these diarrheal diseases. And extreme precipitation helps to spread them in the environment, increasing the fecal oral route of exposure, right? So this is particularly important in the low resource setting where still substantial part of the population practice open defecation and access to safe municipal drinking water remains woefully inadequate. So the second point that I want to make is about the lead time. So what our partners have been telling us is that weather-based warnings do not provide them enough lead time to prepare for the outbreak, so to speak. Whereas climate-based projection with the 50-year, 100-year lead time down the horizon it's too far out to drive meaningful discussion at present about public health adaptation strategies. So what they have been telling us is there's a need for this early warning system with sub-seasonal to seasonal lead time that can help their preparedness activities. And this is where we are coming in. And there have been a lot of really exciting development. So for example, the sub-seasonal to seasonal weather forecasting has improved considerably over even compared to what it was like 5 years ago. We also know that large-scale weather phenomena such as El Nino Southern Oscillation that is known to govern weather regime across the globe can be predicted with fairly accurate prediction with 6 months to a year out in advance. We also know that a lot of the infectious disease have memories. By that, I mean they have seasonal pattern, right? And of course, we have much better understanding of the role played by social determinants of health now. And finally, there has been a lot of really exciting development in the use of sort of like machine learning in public health that enables us to harness all of the powers of each of those independent components that I described. So taken together, it provides us a unique opportunity to develop this early warning system to help public health practitioners prepare for climate change driven risk. Right, so what we are thinking is certainly this, application of such early warning system in terms of ready, set, go framework for public health, where you ready the public health system based on the seasonal forecast, and you set the assets in place based on the sub-seasonal forecast with good 2 to 4 week lead time. And finally, if you still see the risk based on the weather-based warning system, and that will set the everything go, so to speak. And so that's the idea. I think this is really interesting time to be, involved in this work, certainly. And so we hope to partner. We are funded with the National Science Foundation as a part of the Belmont initiative to develop this early warning system for the Asia Pacific region. So what we hope to do is then, once we have this for diarrheal disease, we can expand it to other health, climate sensitive outcome, but then also expand it to other geographic areas. Thank you for your attention.
Thank you so much, Amir. And this makes the end of the presentations from the research today. And I just want to highlight to the audience that the NBEL project is a kind of a one-stop shop for getting access to all these people who are involved in these research projects, if you are interested to follow up more with them. Now it's my pleasure to give the floor here at the Health Pavilion live to Mary Friel, who's a policy and advocacy manager at the British Red Cross. Mary, tell us about how the Red Cross has been dealing with the overlapping climate and health risks, both internationally and here in the UK.
Thank you very much. I'm going to move over so I can move the slides as I talk. So hello, everybody. My name is Mary and I'm from the British Red Cross. The British Red Cross is part of the Red Cross and Red Crescent movement. We're present in 192 countries around the world, present with local volunteers to respond when disaster strikes. And very much the last 18 months has brought into stark focus for many of us the overlapping impacts of extreme weather and health. And to try and make sense of this at a global scale, the International Federation of the Red Cross and Red Crescent, as well as the Red Cross and Red Crescent Climate Centre, published in September the compounding impact of extreme weather events and COVID-19. And what this found was 139 million people had been affected by that overlapping impact of both extreme weather and COVID. And that was resulting from 433 unique weather events. But what does that mean on the ground? Well, the Kenyan National Society of the Red Cross contributed to this research, really told that story of overlapping risks over time, how that builds into humanitarian needs. In Kenya, the Kenyan National Society has been responding to, firstly, extreme floods in 2020 alongside COVID, which has then moved into a period of drought, which currently has over 2 million people facing acute food insecurity. So very much at the front line, seeing that overlapping impact of multiple extreme weather events over time with COVID. And what does that mean for people on the ground? Well, that means rising food prices, it means reduced crop yield, and it is women and children who are on the front line of both of these overlapping crises. But to share as well an example from the British Red Cross in the UK, we are a national society that works both domestically and as well working with sister national societies across the world to provide surge capacity and support in humanitarian contexts. And what we recognised was that actually heat risk was a growing issue within the UK with a significant perception gap. So we commissioned a piece of research called Feeling the Heat, which brings together the latest kind of policy analysis on heat within the UK, as well as offering really practical solutions. So why did we do this? Well, the UK Climate Change Committee on Adaptation warned that the health impacts from heat within the UK is one of the top 8 issues for action from the UK government ahead of the next National Adaptation Programme, which will be published in 2023. We saw very clearly in 2020 the overlapping impacts of extreme heat and COVID as well, that overlapping impact of extreme weather and health. How did we see that? Well, in England alone, very sadly, it was the deadliest year ever recorded by Public Health England, with 2,556 excess heat-related deaths in England alone. And we really wanted to unpack why that was. So as a British Red Cross, we commissioned this piece of research, also trying to understand what were the perception gaps, where were the UK public in understanding the existing level of heat risk to them and to neighbours as well. And what we found was that 1 in 4 people within the UK did not believe that it was hot enough to have a heat wave, despite there being 85 heat waves in the UK declared since 2020. We also find, quite worryingly, that over half of over 75s did not perceive themselves to be an at-risk group. And again, we were concerned about how that perception of not being perceived as being an at-risk group how that would lead on to potentially taking some preventative steps, some really basic steps which can help to save lives. So alongside this policy research, where we've made recommendations on a number of issues around how to involve the voluntary and community sector more in supporting people to get that warning quickly whenever a heat warning goes out. We also thought it was important to publish in a really accessible form heatwave checklist and first aid advice. And we launched this this summer during one of the key UK heat waves in partnership with the Met Office, as they launched their new extreme weather system as well, and also aligned to Public Health England messaging called Beat the Heat. So we saw a kind of a clear gap and a clear role as a Red Cross National Society in trying to tackle that perception gap that exists currently within the UK. And we're currently sharing that with other national societies who may be in a similar position where heat risk is a growing issue. But to conclude, some kind of broader thoughts from having given a little bit of insight on what our global research has said and what we've been doing a little bit more within the UK. I want to just conclude with really the importance of early warning, early action systems. We saw whenever the major cyclone hit in Bangladesh last May, how very, very quickly government, health authorities, volunteers all work together to be able to support people, 2.4 million people, to be able to evacuate quickly and to save lives. And adding on top the COVID-19 pandemic and that additional context, the Bangladesh government opened up 3 times the number of spaces for people to seek shelter in order to facilitate and allow for physical distancing. And the Red Crescent volunteers were on the ground very practically as well, offering support, offering different equipment as well, PPE, to make sure that people were being kept safe. So we see that as like one really, really practical way of being able to take action. Another is about how do we integrate more readily, not just direct public health interventions, but how can we work more creatively, particularly with city planners? So how can we invest more in cool green spaces? How can we make sure that we're investing so that we can help to mitigate the rising temperatures, particularly within urban areas? And finally, to just conclude that with all of this, the importance in everything being locally led, and that investment flows to communities and that they lead that process. Thank you.
Thank you so much, Mary. We will move to our final speaker today, which is Anne Stauffer from the Brussels-based Health and Environment Alliance, where she leads HEAL's activities on climate change, energy and air quality. And after hearing all the speakers from the research side, we would like to ask you, what opportunities do you see to apply what we're learning today about climate and health into policy? And over to you.
Thank you very much for the question, and also thank you very much for the opportunity to be part of this conversation and learn here again on the new evidence on how our health is threatened by climate change and the impacts we're already seeing. I think this is all very relevant, and adaptation as an issue is also something that has increasingly come up in EU policy deliberations. HEAL is an alliance of over 90 member organizations from the health community working for better health through a healthier environment in the European region and beyond. And for the EU, we have recently seen the launch of an updated adaptation plan, which includes health concerns. Importantly, for example, the setting up of a climate and health observatory to gather more data on how our health is being threatened by climate change. I think at the same time, the extreme weather events that we have witnessed across the European region and across the world this summer have also shown us how ill-prepared we still are and how much there is an urgency to look into adapting. And this also reflects what the previous speakers have said about the need to set up good early warning systems and alert systems and responses. We know from other assessments that Europe is actually the region that is most vulnerable to the heat-related impacts of climate change. So I'm particularly concerned here about those people living in cities, the urban environment, and how we can better protect the health there. And I think there is a long way to go in bringing together urban development, city planning, health experts, and policymakers in looking how we can, if you want, climate and health proof our cities in adaptation. And the EU, when it comes to adaptation, the EU very much has to play and should play a leadership role, a global leadership role. And that, of course, also includes providing with the adequate financing for adaptation measures to be taken across the globe. The second point I wanted to make when we're looking at the complex on health, climate change and health is that, of course, we still have time to protect the worst health impacts, and we really have the time, and we need to make the time to look into prevention, and that means, of course, climate mitigation. And as you all gathered at COP, I think it's really key that we have a strong COP outcome, that we have an outcome that commits and puts forward a path really to keeping the world on a 1.5 degrees and to keeping the Paris Climate Agreement goal, and especially consider how we can achieve the swift decarbonization in the next decade, in the years to 2030. And this is also something, a call for stepping up on mitigation is something that has emerged from the global health community. Just before the COP, we've seen a call with a climate prescription, a healthy climate prescription that was initiated by the Global Climate and Health Alliance and others, and a call that has brought together over 400 health organizations and numerous individuals representing 2/3 of the global health workforce in putting forward a strong call to the COP on stepping up, on ensuring that we stay within the 1.5 degrees goal, and as well including that means urgently phasing out fossil fuels and our dependence of fossil fuels. And that ties into also the first presentation that Christine was talking about in terms of the linkages between air pollution and health, where we actually have another opportunity following the launch of the recent WHO air quality guidelines. And we now have the opportunity in the EU, but also in other regions of the world, to set stricter clean air standards, which are an important driver as well for climate action, and which are an important measure as well in our efforts to help adapt to climate change. But as I said, the key message is really that we still have the opportunity, and we need to take the opportunity to prevent the worst health impacts we'll be seeing. Thank you.
Thank you so much, Anne, for this. We are unfortunately running towards the end of our session, but I would like to bring in one question from the audience digitally here at the very end. And I'm hoping perhaps, Mary, you can try to respond to this. And the question is, how do we scale up some of these adaptation actions that the speakers have been talking about today in responding to the increasing risks?
Thanks very much. I mean, there's so many ways, but I would point to maybe two different areas. So one globally, which the Red Cross movement has been really trying to raise as much awareness as possible at COP and beyond, is around the risk-informed early action partnership, which is aiming to make 1 billion people safer from disaster by 2025. This is really practically bringing together the capability of meteorology, of humanitarian organizations, really cross-cutting between governments and private sector to try and make sure that we are better pre-arranging finance and putting in place better early warning systems. So that's a very practical way that things can be scaled up. And we saw some encouraging announcements actually yesterday from the UK government and FCDO on that. And we would hope that that will continue to flow through this conference, because if we can avert and prevent disasters from happening, the worst humanitarian impacts, we have a moral imperative to do that rather than respond. The second is just to pick up on the final contribution was around how do we really take action around and scale up heat interventions, and that needs to happen within city and urban planning. That's absolutely massive. There are so many buildings which are not fit for purpose globally. I know that Europe was highlighted as a particular example for European Union practice, but that is something at a domestic UK level British Red Cross is looking at ahead of the National Adaptation Programme.
Thank you so much. And I think we could have continued discussing this topic, of course, in more length than we had the chance today. So this session has now come to an end, and I would like to thank all the speakers, both here in the room and on Zoom, and also the audience, both here at COP and virtually, for joining us today. And with this, I would just say thank you very much, and let's continue working on this together.